Good evening, ladies and gentlemen. I would like to welcome you to our free webinar, An Alternative to Titanium Implants, Zeramex ceramic implants organized by Nuffield Academy. Tonight, we have the privilege of having our esteemed speaker, Dr. Kumar, to share his wisdom and insights on the topic. Dr. Kumar is the CEO and founder of Nuffield Dental Group with 10 clinics island-wide in Singapore. He's both the director of Zaga Center Singapore and Malo Dental Singapore. And without further ado, Dr. Kumar, please.
Thank you, Ken. Allow me to put up my slides. I'd like to wish everyone a warm, cozy evening in your homes. We took the time at 8 o'clock to be a bit more convenient, I suppose, for those of us who either have had celebrations today, this Indian New Year going on, and for those of us who are preparing for the long weekend ahead of us. Thank you for joining in. I'm looking forward to sharing with you some of my experience with Zeramex ceramic implants. As you know, titanium and zirconia are both materials which can osseointegrate with the bone. And today I shall share with you some cases and some very interesting findings as well. So one of the reasons why I started using ceramic implants was because way back in 2017, there was a patient that came to my clinic in Bedok. And the patient was actually a rheumatologist from Malaysia. And she was actually hunting for someone to remove a failed ceramic implant in her. And it was at that point that I was querying as to why she needed a ceramic implant in the first place. And after speaking to her at length, my interest was piqued. And of course, thereafter, I searched for courses to go on to learn how to place ceramic implants. Of course, there was lots of positive and dreadfully negative data at that point of time. But I decided to further my knowledge to find new clinical outcomes for the patients that would come my way in years thereafter. So let me talk to you about zirconia as a dental implant material and also some of the research findings that we have in the literature. There are known advantages and sadly some limitations of zirconia dental implants from yesteryear, but I would like to convince you otherwise today that zirconia dental implants are really, truly well engineered and planned for use for the years ahead of us. I will present some clinical cases. And of course, I will talk to you about the Zeramex XT implant system, which is already available in Singapore for purchase by clinicians by a company called Medident International, which is a company which I have shareholdings of, I would like to add. But at this point, you must understand why that happened. There was no ceramic implant importer in Singapore. And because I was quite focused and I wanted to bring a zirconia implant material in for my patients, I decided to take up the ownership of the Zeramex XT implant system, distributorship in Singapore. And now we have, as of last December, HSA clearance to sell it to the rest of Singapore. We all know this. We have seen plenty of implants shimmering through thin gingival biotypes. Metal implants, that is titanium, can be unsightly, gray. And sometimes they don't look like actual teeth because of that grayness. With zirconia, because it's white, it doesn't have that problem. Well, let's look at the biological problem ahead of us. Up to 1/3 of our patients who have dental implants end up having periimplantitis. And that's because titanium, being a metal, will attract and collect far much more dental plaque than zirconia, the zirconia material itself. And because the plaque adhesion is higher, that's why you get periimplantitis. There's more research about clean surfaces, of course. And for those of you who have been following the literature, there's a very large company that's actually looking at the surfaces of dental implants, both titanium and ceramic. And what they're looking for is to ensure that there are less contaminants on the implant surfaces. It doesn't mean that a ceramic implant has no contaminants, but there are far much more, in general, contaminants on a metal surface than that of a ceramic surface. Okay, with periumbrantitis, you'll get an acidic environment around your implant, and your implant eventually will be doomed to failure. Now, the benefit of having a ceramic implant is that the gingiva will also form a very nice cuff of long junctional epithelium, allowing a small cuff of tissue, preventing ingress of bacteria apically to destroy the interface between the bone and the implant. Now, of course, many of you, especially the senior surgeons or the senior dentists over here, may have heard that zirconia implants are notorious for breakage. Well, titanium implants can also break. In fact, if implant placement is done incorrectly or without planning for occlusal support or occlusal derangement, you will have patients who end up fracturing both zirconia and titanium implants. But because of the types of implants that were available before for ceramic, yes, there have been fractures before, and many of the reasons are because they use very unfavorable narrow diameter implants. But I'm glad to tell you that this has been overcome. And of course, at that point of time, they were super eager to increase the attachment between bone and the zirconia surface. So they sandblasted the implants with the aggressive alumina sandblasting. And that has obviously led to the implant surface becoming more brittle. And thereafter, you would fracture. In some cases of patients where the patients would have immediate implants, and then obviously you would get implant failure because either there was too early loading, or perhaps the patient would have had an immediate implant, an immediate crown, and the patient was actually just biting far too early and putting too much of load in the first 8 weeks of the implant healing to the bone. We all know that zirconia implants would obviously be more expensive than titanium implants. And once again, we can't definitively say that there's far much more health benefits of a zirconia implant compared to titanium. But however, because of the sheer reason that there are far many more titanium implant companies, obviously zirconia implant companies, which are few in number, would obviously be far much more expensive. But the good news for you is that in terms of both titanium and zirconia, the survivability rates are about the same at a 12-year mark, and more recently 15 to 20 years. If you look at the Titanic, this is at the right at the bottom of the sea. Look at what has happened to the metal. Metal undergoes severe corrosion with time. I see that there are some questions. If there are some questions, please feel free to add them in the Q&A and I'll answer them at the end, okay? Now, if you look at ceramic, here you see a ceramic jug, and this has been around for 2,000 odd years, okay? And you can see there's little change over a period of time, and you can see how much of damage corrosion can cause because of water, and especially halides in the mouth, including chloride ions. Any form of halide ions that you find in the mouth due to saliva will cause breakage and destruction of the implant surface. And in the case of titanium, we do not know where these ions are going to. Further, we also have patients who would come back after a titanium implant placement and say, hey, I feel strange. There is this strange pain. I can't describe it more than uncomfortable sensation. I feel that there's something there. I feel that I'm a bit numb in that area. And you go and check, there is no mobility. And you see that there's no radiolucency on the X-ray. There's no pus. And in fact, you even see that there's no resorption, but the pain still is there. And you want to know what is happening. And in those instances, some of us in the audience would have seen some patients come to our clinics. And some of us who would have taken out those implants, put back another implant, sometimes the pain goes away, and sometimes the pain comes back and the patient finds yet another dentist. So why? Perhaps zirconia is a material which is far much more biocompatible than titanium. Well, that's for me to discuss today, and I will talk to you about some of the findings that we have. Now, the next 3 slides will look at systematic reviews. It's far much easier for us to look at systematic reviews because someone has done the hard work of analyzing lots of clinical data across several papers. In the first paper that I'm sharing, that's in 2008, the study by Wenz et al. the conclusion is that zirconia implants could be an alternative to titanium implants, but were not recommended at that point for routine clinical use, as no long-term clinical data was available. Now, if we look at what has happened to amalgam, the so-called mercury fillings and composites. Now, composites have been around for a relatively small amount of time compared to amalgam. But as you know, more recently, in 2018, in EU, the European Union, banned amalgam to be placed in anyone under the age of 15, and also women who were breastfeeding or who were pregnant. So there's something to be said about materials and what we know about them, and what more findings we get as we understand products, and also the relevant effect on the human body in terms of damage to organs, for it to affect the liver, the kidney. And sometimes these products, the byproducts or corrosion products, can make their way to the brain and across the blood-brain barrier, or even get to a fetus in a pregnant woman. So the reason why I mention is this, because just because a study in 2008 says that there's not sufficient long-term clinical data, doesn't mean that we shouldn't look at it and ask ourselves and convince ourselves that, hey, this is something that is growing, it will take time, but it's something that potentially could be an alternative to titanium for a non-metallic implant solution. Then we move on to 2017, and we're looking at the survival rate and marginal bone loss of a zirconia dental implants, and we find it similar to that of two-piece titanium implants. In 2018, we've seen that there's no significant difference between zirconia or titanium on the results form based on looking at bone to implant contact. And in 2020, Borges et al. Shows that zirconia presents results similar to that of titanium. There was overall failure of 6.8% in 2.75 years in those 19 articles he's talking about. But it also shows that over a short follow-up period of time, perhaps this data is not completely believable by us, and that more long-term studies need to be done. We move on to other studies that tell us that there's no difference between the rate of osseointegration in animal studies between that of titanium and zirconia. Further, when the first zirconia implants were made, they were severely blasted with the alumina, and this led to lots of brittle surfaces. Then what happened was that zirconia implants were started to be acid etched instead, and this was found to reduce the brittleness of the surface of zirconia, and this actually improved the osseointegration. More about this when we talk about and look at the Zeramex XT implant. There have obviously been people trying to use this in all-on-4 situations, so the edentulous mandible and the maxilla, and the studies actually show us that zirconia has the same sort of bone implant contact similar to that of titanium in those studies. And of course, Sivaraman in 2018, which is a critical review looking at multiple papers, looked at the potential of two-piece zirconia implant, but criticized a one-piece zirconia implant, especially in the posterior region, because it's a problem in terms of a restorative conundrum, where a one-piece implant seemed to be an ideal implant to be placed because of the lack of a zone there where bacteria would form. But the problem, of course, remains that you can't restore this easily because you get lots of food trap at the sides of the implant crown. Now we move over to 2019, where the studies done by Rowling et al. They looked at 37 preclinical studies looking at both the materials in both with regards to soft and hard tissue. And they clearly show that both titanium and zirconia have similar soft and hard tissue integration capacity. Although it says that titanium shows a faster initial osseointegration process, we all know it doesn't really matter how long it takes for osseointegration. What's more important is that it osseointegrates by the time we restore it with a crown. Okay, and we look at further studies. Further studies, of course, tell us that zirconia implants may show higher crestal bone loss compared to titanium. The problem with that study that RRAG presented is that they had a very, very high heterogeneous result. So that means that you can't actually trust the results that have been presented in these 6 studies. Further, we look at Comiso, who then presented a systematic review of 15 articles. And obviously, this is the easiest thing for us to all believe that zirconia implants, one, have much better aesthetic outcomes than titanium implants, less plaque accumulation, and less inflammation around the peri-implant mucosa compared to that of titanium. But I already mentioned as to why that's the case. Now, let's look at the advantages and limitations of zirconia. We already know that zirconia is going to be a far much more aesthetic dental implant versus titanium. We have already looked at zirconia posts in root canal treated teeth. We know we wanted to move towards zirconia rather than metal because it is far much more aesthetic and was trans-illuminable. And we also know that zirconia posts in root canal treated teeth are more expensive. So it's no surprise that zirconia dental implants will also follow suit. But the most important thing here is that it is a non-metal implant, and where a patient desires an implant and has a known metal allergy, this is probably the best chance they have if they want a fixed restoration in their mouth. Now, although we know there are many studies, the studies obviously are not as long-term compared to the ones that we have with titanium. But as I said to you before, just because we haven't had enough time to assess the product properly, it doesn't mean that we give up on this product. Most of the patients that I have, it's amazing to see a zirconia implant crown, which obviously collects much less plaque than a porcelain fused to metal crown. But more interestingly around a zirconia dental implant, I see two things. I noticed that there is the process of gingival creep, allowing the gingiva to creep up the surface of both the implant and obviously if you have a zirconia crown as well. There's much less plaque accumulation around a zirconia implant and an implant zirconia crown compared to that of a titanium. Now, I had a patient that came to me from Brunei, and this particular patient has had, he had traveled both to Australia and Malaysia. That's part of his work. So he traveled those places for that reason. He ended up in Singapore, and his crown had fractured, and that's the reason why he came to see me. So when he saw me, he said, look, two dentists have really tried to put crowns on this implant of mine. It's a ceramic implant. I placed it many years ago. Before he opened his mouth, I already knew that it was going to be a small diameter zirconia implant. And that's the problem I had. So I then made a crown for him, which obviously had a huge food trap, as you can imagine, both on mesial and distal areas. I cemented it in with Rely X. And 3 years later, he came back and the same crown had fractured. Of course, he was a bruxer. Of course, patients who have all these problems are all bruxers, of course, as we obviously endure. And that's because these patients are usually in high-stress jobs. And what I had to do in the end for him was I had to remove that one-piece implant and place a two-piece implant. We all know one-piece implants have prosthodontic challenges, okay? And the instance of zirconia implants, we do not have a multi-unit abutment for all-on-4 style tilted implants. But the benefits of this, I'll tell you now, I don't see as much periimplantitis in my patients who have had zirconia implants compared to patients who have had titanium implants. Now, whether they have a reduced systemic absorption or effect, it's completely up to you whether you wish to believe or not. But I've seen plenty of patients coming through who have eczema, rheumatoid arthritis, patients who have systemic chronic granulomatous conditions, sarcoidosis, searching for someone, and they do not want to upset their immune system for this. There are many patients around the world that head towards Switzerland, very famed for having lots of ceramic implant systems, as I'm told, holistic treatment, where dentists treat the patients who will then disinfect the extraction sites with ozone and put platelet-rich fibrin. Well, we have all of this now in Southeast Asia. Let's look at the first case. This case is a case very, very close to me. Let me tell you a bit about him. It's a 43-year-old male who called me one evening and said that my tooth is moving on the bottom left-hand side. So I then saw him quite quickly. I had to see him quite quickly, you see, because he's my brother. Now, my brother has a history of grass, pollen allergies, dust mite allergies. He had eczema as a child and childhood asthma. Now, 1 year after I placed the titanium implant in him, and mind you, this implant was done as an immediate implant, of course. Tooth came out, implant went in. 4 months later, we restored the implant. 1 year after this, the implant became loose. And at that point of time, when I first had placed the implant, I did not have a ceramic implant as an option for him. But of course, come a few years later, after the involvement with that first patient I saw from Malaysia, I had already told myself that perhaps if I had an opportunity to place a ceramic implant in a patient who would fit the criteria of someone who has allergies, I would do so. And then my brother says, my implant is shaky. I think there's a problem. So as we would all do, we take an X-ray and we would assume that it's the abutment screw that is a bit loose. So we access the screw channel and we try and tighten. But lo and behold, the implant had failed. So I took out the implant and then waited for a month before going back in again. And this is the tissue response around the implant, as you can see. So that is a Zeramex P6 implant. That is the slightly older generation implant that Zeramex had. It's a very, very good implant system. But I now have a new system, which I'll talk to you about. This is the P6 system, and the new system is the XT system. And you can see here, if you look at the keratinization of the adjacent mucosa around the implant, you can see, and you will agree with me, that the tissue response is impeccable. Let's look at case number 2. This is a 46-year-old Chinese lady who came in, unrestorable upper left 1. I took out the tooth, placed an implant immediately, and I also loaded it at the same time. You can see the clinical results over here. You can even see exactly where I've made the incisions to raise my mucoparietal flap. Now you can see over here, the gingival cuff around the crown of the implant is fantastic. And in terms of the effect it has, if I had a titanium implant over here, I might see a gray hue over there. Some of you may argue and say, but hang on, you would have added some bone graft, didn't you? I did not add bone graft in this case. And the reason for that is she had a much thicker buccal bone labial plate. There was no need to. I don't routinely do this for patients who have anterior implants placed in my practice. But in this particular case, I want to tell you that because it is a white implant surface, the tissue aesthetics is far much more superior than that of a titanium one. This is the tissue response you can see. Now for the third case, I'm just going to show you a sprinkling of cases, okay? Some of these cases are not complete, of course, but there are good reasons as to why I show you, because I want to show you the variety and the flavor of what sort of implant indications you can have. Now, this patient is a 52-year-old Caucasian patient. He came in with a cracked lower right 7. I proceeded to remove the tooth and placed a Zeramex white base implant, okay, immediately, right? So I took the tooth out and placed an implant. And that's the restoration. Some of you may argue and say that, hey, there's initial bone loss over here. But if you look actually carefully, that's the top of the implant and this part over here. So I'll talk to you about the Zermax implant surface in a short while. And the neck and the actual body of the implant is actually different in terms of the polish. It's a polished surface for the neck. And what you see over here is there's no gap between the crown and the implant, okay? You can see in certain implant systems, there will be a gap. There'll be a slight gap. The Zeramex system doesn't allow for this. It wants a very, very tight adaptation of both the tie base, or not tie base equivalent of the titanium base is not present in a Zeramex system, but it has a ceramic abutment, which obviously is torqued into the ceramic implant fixture itself, and there's usually no gap when you look at this on an X-ray. Now let's look at case 4. This patient is a 50-year-old female with an atrophic ridge at the upper right 6 area, and this is about 3 millimeters in height. So I'd have to perform a lateral window sinus lift, of course. And so I placed a wide body. So the Zeramex implant system has both a narrow, a regular, and a wide body. Okay, the wide body is fantastic for molars because the emergent profile is beautiful. It's much larger. As you can see over here, the window has been accessed. I've used osteon, bone particles to be put inside. Now, for all my sinus lifts, I always routinely take platelet-rich fibrin. I harvest 18, 20 mils of blood from the patient's cubital fossa, and I'll mix this with the bone, and then I'll get a very, very nice sticky bone mass, and that goes into the sinus. And I put on top of that something which you see over here. It's called Osteomesh. I've already mentioned this in some talks before. Some of you who have been following my talks will know that Osteomesh is a fantastic material. It's made of polycaprolactone, and it's a very, very good material because not only does it convert to bone, it also sticks to the tissue surface and thickens the area in preparation for good attached gingiva. And here you can see the sutures that have been placed around the implant, and that's actually a cover screw, not a healing abutment for this particular Zeramex implant. And here you see the implant that has been placed simultaneously with a sinus lift at the same time. This is case number 5. This is a 34-year-old female Malaysian stuck in Singapore. Unfortunately, couldn't go back to Malaysia to finish up her orthodontic treatment and had also missing upper first premolars. So when I saw her, I said, hey, you have a lot of spacing. And she said, look, just remove all these brackets off me. So I did that for her. And then she said, can you do anything for me? I said, I can do plenty for you. So after the debonding, I just prepped her for Invisalign, and then we started after one round of gingival, subgingival debridement, we decided to proceed with Invisalign. So we did Invisalign, aligned the teeth, and then placed 2 implants. Of course, these are ceramic implants. So the implants were placed 9 months post Invisalign, and that's her at the moment. You can see that these are the 2 crowns. The implants were restored 4 months later. And why am I showing you this case? It's a very simple, straightforward case, I suppose. But the illustration here is that you've seen a case of immediate implant placement. You've seen a case of an implant that's been placed at the same time as lateral window sinus lift. And you've seen a case of where I've used Zeramex implants, a ceramic implant, in what you would imagine to be a very atrophic site, because this patient has had not had a premolar there for a long, long time. This last case is also quite interesting, and we'll spend a bit of time talking about this case. This is a 33-year-old female. She came in complaining of pain past the usual mobility of a lower left 6 with a previous history of root canal treatment, and obviously has chronic apical perio. She came to me and I took an x-ray, and it looked like that. Okay, so the previous one was the x-ray that she brought in to show me the history of this tooth. By the time she had seen me, it had already been 1 month since the extraction. Now, of course, the discerning amongst you would obviously say that, hey, hang on, you didn't have a chance to curette that site. Are you planning to place an implant straight away? I routinely curette the extraction sites, whether it was done by me or done by someone else. But this ended up being a delayed implant placement, and I restored the implant crown for her. Now, 1 year later, of course, she comes back to me and says, there's a problem. The implant is loose. I said, how can the implant be loose? So I take an x-ray and I see a lot of bone loss. And then I look in the mouth and I see the tooth moving around. So I remove the implant and then I place a ceramic implant. Now, what I haven't mentioned to you is that by the time she had that titanium implant removed to the point where she had the ceramic implants, that was about a month. I always give these patients about a month rest to allow the bone to heal and for any infection to surface. When she turned up on the day of surgery, we were planning to put a titanium implant back in. And then all of a sudden she tells me, in fact, I noticed that she wasn't wearing a watch. She wasn't wearing any chains. I said, why aren't you wearing any form of jewelry on you? Oh, I have a very bad allergy to certain metals. I said, oh, really? Tell me. Oh, for example, I had a titanium stud on my belly button and that got really badly infected. It took like 6 months for the infection to clear. So I went like, and you only decided to tell me this now. So based on that, I said, immediately this surgery was just about to happen. We'd opened up a dentium kit for her to have a titanium implant placed. And then I said, you know, I think it'd be just easier for all of us, just for my own sanity as well, if we placed a ceramic implant instead. And once she heard that there was such an option, she said, just go ahead. This was only done this last week. And only time will tell whether we're going to be successful. But what is important to know over here is that some patients will not tell you these things until you probe and ask. And only when you ask, for some reason, does the patient think that is actually something that a dentist needs to know. Let's look at the ceramic implant that we have in Singapore today. I believe Straumann also has a ceramic implant that they were either about to bring to Singapore or already has been in Singapore. The Zeramex XT implant system, for all of you who are here today, you should know that Nobel Biocare has a contract with Dental Point AG, who manufactures Zeramex implants. So the Nobel Pearl, which is the Nobel Biocare ceramic implant, is actually manufactured by the same company that manufactures the Zeramex implant. In fact, they are exactly the same. So the Zeramex implant, if it comes in a pink box, it's a Zeramex implant. If it comes in a white box, it's called a Nobel Pearl implant. Okay, so this is a new generation of ceramic implants. The material that is used is different from before. It's been treated and ensured that the zirconia that's used now is far much more resistant to fracture and can be made to have two parts, which means you can have platform switching, you can have a much larger base, and you can have lots of interesting threads, grooves that the older zirconia implant systems were unable to have. Now, of course, you want to make sure that whatever you use is not metal. And of course, many of you might be wondering, aren't you going to be using a metal screw inside to retain the abutment to the implant fixture? No, it's a carbon screw, right? So it's a carbon screw. It's called a bicarbo screw, and that's a trademark of the screw that they use. It has, it acts like a bolt. Okay, so what happens there are 4 interlocks of the abutment into the implant fixture itself. So there are 4 interlocks. It goes in, and then you get a screw that goes inside, which is made out of carbon. Now, interesting, this particular screw, when you put it in, it's meant to be put in once and torqued to the maximum, and thereafter, it's not meant to be removed anymore. So I have yet to have screw loosening in a titanium, in a Zermax patient, just because of the screw. In fact, if you want to remove the carbon screw, it's a challenge. You would have to cut a groove in it and unscrew it anti-clockwise. So for those of you who had problems with patients with Brux, patients who've got lots of eccentric movements, parafunctional habits, and you've had lots of screw loosening, here's an implant system where the screw actually molds to the surface, to the surface of the, where the threads are for the implant abutment screw, and it prevents loosening. So I'm excited to tell you that if you have such patients who have lots of regular loosening, and if you have any desire to replace an old implant system for the patient, you may wish to consider a Zermax implant system, because it is true, I don't have screw loosening in this patient group. Now, I mentioned to you before that 3 types of sizes that the Zermax implants come in. It's SB, which is the smallest size. And then you have RB, which is the regular base. And then there's WB, which is the wide base. Okay. The surface of the implant is known as a Zerafill. That's their own trademark, of course. And it's a microstructured implant surface. And it's been acid etched. As I said to you before, in the past, they used to blast these things with aluminum oxide, making the surface very brittle. Now they just etch the surface. And you'll be very happy to note that Zermax is committed to the clean implant foundation. And they also want to ensure that the products are always consistently free of any form of surface impurities as well. As I mentioned to you before, Zermax implants enjoy the flexibility of having platform switching. For those of you who know what platform switching does for implants, it's fantastic, because it allows, 1, it reduces potential crestal bone loss. Number 2, it allows more soft tissue ingress to allow thicker volume around the implant platform. And of course, you have to note that it's not every single, so an SB, for example, could be used on, you can't use a wide base abutment on an SB, which means you can't use the wide base abutment on the smallest implant, Zermax implant system, but the rest of the swaps you can put a a smaller abutment on a wide base or a smaller abutment on a regular platform. Okay, so that's good to know. And just a small note again, with regards to the bicarbo screw. The bicarbo screw is used, you can torque it at 15 newtons if you want to do a try-in of your implant crown or implant bridge. But thereafter, once you torque it at 25 or 30, that's it. It's very difficult to remove. It will intentionally deform and prevent you from removing it easily. You would literally have to cut a groove and remove it using a flat implant driver. All right, so we've come to the end of the presentation. I'd like to thank Ken for setting up this talk for me. Just a small sort of mini advert for those of you who know about the Orosil, a mouthwash that was launched by Medident. Orosil Orange is povidone iodine at 1%. This has been recently sent to all households by Temasek Foundation. And Orosil Green is chlorhexidine mouthwash, which we have at Medident. For some of you who might be interested in doing platelet-rich fibrin in dentistry, the current news in Singapore for platelet-rich fibrin is in conjunction with particulate bone. I like to use synthetic bone. So I always tell my patients that I make it biological by using platelet-rich fibrin. And this particular course is aimed at both educating your nurses as to what sort of setup you would need and the dentists to actually practice venipuncture on themselves. And of course, to find out what centrifuging protocols we use to make the platelet-rich fibrin actually work with the particulate bone. I know lots of people who go on courses and come back and tell me that they can't get sticky bone. But we'll show you how, of course. And the next course, which will be on the 28th and 29th of May, it's a 2-day clinical residency program for those of you interested in all-on-4 dental implants. This particular implant program will not be using ceramic implants, of course. As I've told you before, multi-unit abutments are not available at current time for ceramic implants. And for those of you who want to know, it's about 16 CPE if you want to add, collect CPE points for the next 2 years. Now, I'd like to thank all of you for coming and listening to this webinar, of course. Now, if you want to contact anyone with regards to buying Zermax implants, please kindly contact Sneha. That's a number at the bottom, and that's an email address. For those participants who have signed up today, I believe there's some special rates they're looking for that they arranged for you. Please contact so that you will be able to get these rates. In terms of clinical sort of mentoring, for those of you interested, and once again, as I said, there is some difference in terms of how we place a titanium implant and a Zeramex ceramic implant. And that's just owing to the protocol that the company has to ensure success. You can obviously ask me, and I will be around to show you and take you through some situations and perhaps even a familiarization of the kit and the prosthetic elements as well. Once again, the person you should contact is Sneha. Her number is down there and her email address is down there as well. Thank you. Right, so Ken, let's look at some questions.
Dr. Kumar, there's actually a question from one of the attendees.
Yeah.
Have you had any patients responding negatively to zirconia implants?
Yes, I have had one patient who responded negatively to, so this is life. When you have a failure in any sort of prosthodontic or surgical aspect, you need to ask yourself as to why this has happened. So I had a patient, of course, I placed a titanium implant, and then I decided to place a zirconia implant because the titanium implant had failed and the zirconia implant failed. Now, many of us would just give up, right? But I didn't decide to give up, of course. And at that point of time, I just come back from an implant conference where they were talking about vitamin D and how valuable it was in terms of bone healing. I then told the patient to do a vitamin D test. And lo and behold, the vitamin D levels were far much lower than normal. So I got the patient to have vitamin D. The patient came back. I redid the implant, of course, and then it was successful. So just sharing this purely because if I had not gone for that conference, I would not have thought about wondering about the vitamin D levels of the patient. Yes, that implant had failed. So a zirconia implant will not do a magic show in someone who's got decreased vitamin D levels. Next question, Ken.
There's actually I think a gentleman or lady, Teo Gyok Ming, has raised his or her hand.
Yes.
You want to ask the question?
Where's the question?
Gyok Ming, the question? Oh, I think it's a mistake.
Okay, any other further questions? Okay, so Surinder has actually asked a question of whether PEEK is BPA free. I actually do not know the answer for the question. BPA, as we know, is bisphenol A, and there are lots of patients these days who actually ask us whether the composite fillings they're actually getting are BPA free. I do not know whether this particular product is BPA free. I will ask Dental Point and find out for you.
Thank you.
Any further questions? Right, if there are no further questions, I'm just going to say a few more things before we end this evening's talk. I'd like to thank everyone who actually has made this effort to come down, because you have been curious to find out why I have been placing ceramic implants, the existence of ceramic implants, and two, why there's been such negative press about ceramic implants. But more importantly, the very fact that you are here shows that you want to know what advances that happen in the realm of ceramic dentistry. Zirconia, as you know, it's a very difficult material to handle even in the laboratory. We've got tons of problems with zirconia in terms of the color matches. Very frequently, we're so used to having great shade matches with PFMs and Emax. And then here you have zirconia, which comes in blanks, ugly, very high value opaque blanks. And to make them translucent and to give character to anterior teeth is very difficult. Manipulation of zirconia has been characteristically difficult for many, many years. Okay, and it's only now that we've been able to get a two-piece implant. The P6 implant was the first two-piece implant that Zeramex came up with. And the XT implant is a very different sort of implant, because the P6 implant was an external hex implant. And the XT implant now that Zeramex now uses, the P6 implant is still available, but not available in Singapore. The P6 implant is external hex. The XT implant is internal hex. For those of you who use internal hex, you'll find that internal hex is very much easier to restore, much easier for you to place. And of course, lots of things which some of the senior surgeons will tell you external hex implants are good for, it also has, because of the design of the implant itself, in terms of the neck and the design of the implant threads. I would also have to say at this point that because there's a flexibility of Zeramex to have different sort of platform switching, it allows us to actually really take advantage of, we want to see lots of fat molar emergent profiles, because this really reduces the amount of food getting stuck around an implant crown. And as we know, as much as we want our patients to floss and use water picks, they don't. Okay, so this has all been now rectified with the designs that we have. I know some of us over here like white base implants, and I very, very commonly use the white base implant for even premolars at times, and definitely molars. For the anterior region, I tend to use the regular base, and for lateral incisors, I obviously use the smallest platform. They have the SB. In terms of what I prefer for anterior implants, I usually load my anterior implants, Zeramex ceramic implants, and I load them. Sometimes I use socket shield. Some of you are familiar with this. You have a tooth, you just remove most of the tooth and leave a very thin sliver of tooth material, so that it's attached to that remaining buccal bone, and I place the Zermax implant posterior to this. In those instances, I would not use a bone graft. I would then sometimes raise the flap to ensure that there's no periapical pathology that's not eliminated. And I would still place a temporary restoration that is loaded on the same day. My frequent my most favorite and frequent biological dental procedure I do is to harvest blood for the purposes of platelet-rich fibrin. Lovely procedure, something which you should all try and do and at least understand why and how different it handles. You can make lots of lovely membranes using platelet-rich fibrin, but the fantastic thing is that if you've had patients where you've had lots of particulate bone coming out from the bone graft augment site, if you use a sticky bone, and it's truly sticky when I say sticky, I mean like you can pull the whole thing and it moves like this, yes? If you can do sticky bone with that consistency and use either a membrane or a PRF membrane as well, you get one, fantastic tissue healing, and two, you get very, very lovely gingival aesthetics around your implant, especially in the anterior region. Okay, so for those of you who are chasing the ideal implant aesthetics, I'd like to advise you to consider the use of a ceramic implant. For those of you who wish to see a ceramic implant procedure being done, please kindly contact Sneha. We might be able to do some mentoring for you as well. With that, I'd like to thank everyone for joining this evening.
Dr. Kumar, there's actually 3 questions asked, one in the chat and 2 in the Q&A. Let me share with you the one in the chat. Does ceramic implants break more easily than titanium implant?
So we have already mentioned this before. In the past, it was very obviously a problem because ceramic implants, the manufacturing process had not been completely understood and perfected. And I also told you that the surface was blasted by sand particles, aluminum oxide particles. We don't do that anymore. We actually now use, we etch the surface of the zirconia to prevent it to being too brittle. Now, is a ceramic implant more brittle than a titanium implant? The answer is yes, but they're about the same in terms of the amount of fractures you would see over a period of 5 years, 10 years. Lots of studies around to tell us whether the longevity studies of an implant lasting 5 or 10 years, both for ceramic and titanium. My opinion is at this point of time, it is safe enough for us to use confidently in our patients, and certainly my patients. I've been using it for the last, since 2017, as I've said. I have not had any implant breakages.
Here, the question in the Q&A, any real osteo integration of ceramic implants like titanium implants?
Okay, I will answer this question. For those of you who actually think titanium implants completely also integrate, you have to be, you'll be very surprised. Unfortunately, the truth is that you don't get 100% also integration around a titanium implant. You don't. And there are many reasons for this, okay? Firstly, there are lots of impurities on the implant surface of a titanium implant or a ceramic implant for the matter. If you take a look at any form of OPGs or periapicals or CT scans, you will always find some small little gap between your implant and the bone. And you're wondering, what did you do wrong? How come it doesn't integrate? And the reason for that is because of all these small impurities. And because of that, you have a general concern whenever you do an X-ray. You say, I'm not sure the implant has healed. This has happened not just for me, it happened to many implant surgeons, okay? Now, in the instance of zirconia, zirconia forms an oxide layer between the bone and the zirconia surface. And this oxide layer prevents ingress of bacteria to the point where if bacteria cannot go down the implant threads, you don't get this problem with periimplantitis. Well, you do get periimplantitis for any. The moment you place an implant in the mouth, you have to understand it will start to fail. That's number one, okay? However good the control of oral hygiene is, it will start to fail. You have to accept this. However, with good oral hygiene and good cleaning aids and good practices, you'd obviously get good habits for the patient to keep the implant longer in the mouth. But here is an implant system which has the ability to have a good gingival cuff and good long junctional epithelium forming around it, and with a corrosion layer preventing bacteria from going right down to the depths of it. Okay, Dr. Jetty has asked a question for anterior cases, the best position to sink the ceramic implant for best prosthetic emergence profile. Okay, for best prosthetic emergence profile, okay, for the emergence profile, it's obviously better to sink the implant subcrestal. But the good news for all of us is that Zeramex has angulated abutments. It does not have an angulated abutment screw, but it has angulated abutments. If you want the best emergence profile for your ceramic implant, For the purposes of a titanium implant, you would place the implant subgingivally, and you would like a lot of thick gingival tissue buckled to your implant. Now, for the case in a ceramic implant such as Zeramex, the implant is actually placed supracrestal. You place the Zeramex implant up to 0.6 millimeters supracrestally, especially in the anterior region. And purely because the implant abutment, the neck of the implant fixture, the neck of the implant fixture is smooth, it actually sticks very well to gingiva. So for me, in my practice, for a titanium implant, anteriorly, I would place it subcrestally. For a Zeramex XT implant, I would place the implant slightly supragingivally. I would place it supracrestally, up to 0.6 millimeters. Of course, you can't be precise in that, but it's just above the level of the crestal bone. So Dr. Faisal's question, are the Zeramex implants bone level or tissue level implants? They can be both. Most of the advantages seem to be good long junctional epithelium, in addition to the ceramic. Can we get similar results with a bone level titanium implant with a zirconia? Yes, you can, but you have to communicate to your laboratory. If a zirconia abutment is polished and so here you are, you have a lovely zirconia crown, okay? It's super polished, of course, but the tissue surface is also highly polished. You are not going to get much long junctional epithelium over there. You have to instruct your lab to treat the surface. Don't over-treat the surface. Don't polish it. They can sandblast the area to make it rough. Yes, and that should improve some form of long junctional epithelium forming between the tissue surface of a zirconia abutment and to the surrounding gingiva. But in terms of asking me whether it's going to be similar results to a bone-level titanium implant, once again, as I said to you before, a bone-level titanium implant never, ever truly gets 100% implant and bone fusion. It never does that. If you don't believe me, take a look at all your x-rays. Take a look with PAs, periapicals. You will never get full bone contact to your implant, okay? However, if you look at zirconia implants, and I'm not saying that all of the zirconia implants will have exactly the same result, but plenty of them, you'd see far much better bone apposition to the implant surface for that of a zirconia implant. I hope that was useful.
Dr. Kumar, one question in the chat. How about biocompatibility of ceramic implants?
I'm not sure what exactly that means, but a ceramic implant that is placed in the mouth, such as Zeramex, is biocompatible to both bone and gingiva. So there isn't any problem in terms of versus titanium, which is more biocompatible in terms of osseointegration with the bone, but we would obviously have a problem with the gingiva. So it's far much more biocompatible compared to a titanium implant in the mouth, purely just because, as many people will say, gingiva loves zirconia, zirconia loves gingiva. So I hope that answers your question about the biocompatibility of ceramic implants.
Dr. Kumar, no more questions?
Okay, I've said this a few times again. It's for up to all of us to look at new products in the market. And of course, if there's lots of good research that supports the use of them, certainly it's best to find someone who has done a lot of this before. In Singapore, I would say that probably I've done the most in Singapore, and very happy to take you through procedures which I have done in the past, or even show you how the kit works, or surgically there's some tips and tricks which can be used. I have had multiple issues with regards to the armamentarium. There is both surgically and prosthetically, okay? So for those who've had problems with fractured abutment screws, fractured implants, fractured carriers for implants in a titanium world, well, I've experienced all of this in the ceramic world. So if there are any form of questions or perhaps any surgical tips I can share with you, we can certainly meet up in person again and then talk to you this and tell you how I've overcome this and what tips and tricks I can give you so that this will not happen in your hands. Because having a Zeramex bicarbo screw stuck inside an abutment that you want to remove is very, very, very annoying. And I've got some tips and tricks to share for those of you who'll be interested. But it's something which, as I said, is not simple compared to a titanium implant. Titanium implant, a new graduate can place a titanium implant, but I would certainly not advise anyone who's brand new to implants to start with the zirconia implants. Completely different level ball game altogether. And there's a small learning curve which you will need to overcome. But once you start, it's a very, very lovely world of biological dentistry ahead of you. With that, thank you very much, everyone. Good night.